So let's spend a moment on a meta-analysis, a recent meta-analysis, and a meta-analysis that can be quite instructive for understanding these issues of heterogeneity and the interpretation of that data based on minimal clinically important differences. Basically, what they identified when looking at the abstract, and it's a useful place to start at any meta-analysis, is that randomized trials in any language that compared viscosupplementation with sham or intervention or non-intervention control in adults with knee osteoarthritis. Very reasonable and very good in that you would give you assurance that they've looked at or attempting to look at high quality data. They looked at primary outcomes that seemed very logical and important, right, given the purported effects of viscosupplementation. And they also looked at important secondary outcomes. When you look at the overall data synthesis, you see a number of patients, just under 10,000, 71 trials. So it's a very large number of trials, which is good. And they also showed here, and again, remember, they showed here a statistically significant improvement in pain. Keep that in mind, right? And the effect size is 0.37, which is considered to be a fairly moderate effect size. The confidence interval is very wide, but still does not exclude a non-effect. In other words, there is significance here. The other thing they state here is there's important between trial heterogeneity. So once again, go back to the primer. The minute you see that, the first thing you're asking yourself is, did they explore why trials were heterogeneous? And then, should we ultimately be looking at the overall pooled estimate of effect as the effect that we're going to believe? If there's lots of heterogeneity, one might argue, let's not look at the effect overall. Let's look at, trying to understand where those sources of heterogeneity were. And ultimately, they also showed overall that there were a number of trials that showed that viscosupplementation increased the risk for serious adverse events. Once again, go back and look at the definition of what a serious adverse event is, both from a point of view of biological rationale and also from the point of view of, this is a potentially serious finding if, in fact, it is robust and true. So again, looking at this, you can see that this is a major driver of concern if this is, in fact, true. Look at the limitation section as reported in the paper. Trial quality was generally low. Once again, when you see that, you ask yourself, how believable are we going to be looking at the overall pooled effects if we don't believe the quality of the primary studies are good? So this is a challenge with many meta-analyses, but at some point you have to make decisions. You have to say, okay, well, what is the quality of the data we have, and how can we use it to further our knowledge? So we don't want to always throw out every trial just because we think it's low quality, but we want to understand in context, do we need to do more trials? Do we have an answer? Or do we need to do more analysis? And ultimately, you have to temper that with the overall conclusion. In this particular case, the conclusion is that they had a clinically unimportant effect, which meant that it didn't meet a threshold of importance that were set out, and we'll learn about that. But it did have a statistically significant benefit. So this issue of statistical significance versus clinical importance. Also important occasionally to understand who's funded it, because there's always sources of influence in the lens in which people look. So the extent to which you are interested in understanding conflicts, you should be exploring that in every publication. But let's, for the time being, assume that this meta-analysis is high quality and we take the results exactly as they are. To be most instructive, let's look at the tables and simply just try to interpret the tables. So this is a segment of a figure that was taken from that particular meta-analysis in 2012. And you can see that this is the bottom half of that figure that's looking overall at the effect of viscosupplementation versus some control. And you can see here there's a red line, which is the sort of the central line of no difference. And then there's also a dotted line, and there's a zone here in blue, which is this what I think is being termed, or what we'll term, the zone of clinical importance. So fundamentally, that if a line is to the left of that red line, it will ultimately be something that we would interpret as statistically significant. If the overall effect is beyond the blue, so to the left of the blue, we would argue that it's not only statistically significant, but it's clinically important. And again, these are simply based on the exact assumptions that the authors have used. There's no interpretation beyond that, and this would be some way that we would interpret by their own guidelines how to interpret this information. So one thing you look at here, when you look at across the red line, you say, okay, well, it looks like there's a lot of the overall point of, estimates of effect, which are the squares. The majority of them sit to the left, right? So there's probably some statistically significant effect that's going on. That bears out in the very bottom, which is that open diamond. That open diamond is the overall pooled effect. And then you say to yourself, well, if we look at that dotted line on the left, which is that, sort of the threshold of the zone of clinical importance versus unimportance, you can see that there are some trials that kind of go beyond it. There's maybe a third or a fourth of them, at least, that look like they're beyond that in terms of the point estimate. And then there's a bunch that are on the other side. So really the heterogeneity seems to be around clinical importance, more so than it is around, whether there's an effect or not, fundamentally. So the question you'd ask yourself is, as the authors did, is that there's a lot of heterogeneity. What's the thing you do when you see heterogeneity? You start exploring why. So what are some of the things, and I get you to think to yourself, what are some of the things you'd want to know? And there's a lot of things that were tested. But the few things I'd like to know would be, is it some formulation issue? There's so many different formulations that have been used. Is there some formulation issue that we could look at? Is it an issue of follow-up? Is it the issue of who funded the trial? People think of sometimes around biases around who the funders are. Could lead to major shifts in how these how the results are ultimately presented. So here's a couple of examples that we can go through, and I'll go through one, and I'll be asking you to interpret the other on your own. So this is that zone I'm talking about. So let's look at some subgroups. Let's look at structure, molecular weight, and follow-up. And again, these are taken exactly from the appendices of this paper. They have not been modified. They are what they are being presented as. So if you were to look at this particular one, let me help you interpret the follow-up duration, and I'll get you to think through quickly about structure and molecular weight. The way I interpret the follow-up duration would be that viscosupplementation seems to have both a statistically significant and a clinically important effect at less than 3 months. So basically, it seems to have a maximal effect in that first 12 weeks post-injection. As we go towards 6 months and a year, we see that there's still a statistically significant improvement in pain, but the clinical effect wanes and wears. So if you look at that from the point of view of pragmatics, that's probably how many of you may see that happening in your patient population. Now, does this mean that this is an absolute finding? Absolutely not. These are subgroups, means these are hypothesis generating, but they give us a little more insight, right? They help us understand a little bit about where this heterogeneity may be coming from. So I want you to take a second, and I want you to think about molecular weight and in structure, and ask yourself this. If you had to pick across all the different types and formulations of viscosupplementation, which ones would you be at least putting a little bit more of your energy and effort into thinking about? So I'm going to give you 10 seconds here to think about that, and then we'll go through it. So I hope you had a chance to think about it, but the way I look at this is that if I had my choice to think about based on the evidence, that we would at least be considering and exploring the use of cross-linked and high or very high molecular weight preparations. Again, simply based on interpretation of the evidence we have from randomized clinical trials, it would suggest that cross-linked preparations and or high or very high molecular weight preparations seem to meet the threshold of clinical and statistical significance. Now, we can explore how valid subgroup analyses are in a different section, but fundamentally, interpretation of this data set would at least make you think that we should be exploring those areas. What about industry conflicts? So when you think about industry conflicts in trials, there has been this purported belief that industry funding can sometimes lead to an exaggerated treatment effect in favor of the industry product. And in fact, when we look at this, we would think then that non-industry funded trials would probably be more negative than positive. So when we look at this particular section, which is an important section to put and to interpret, it suggests two things. One is, it suggests that the majority of studies in this area have been funded by industry, and there's lots of reasons why, and it's probably largely because government funding agencies just wouldn't be funding these types of trials across any sort of innovation or any sort of drug. There's just been a change in that. So that's a challenge that is hard to overcome. And I mean, a few number of trials here. These include about 4 trials that have been funding independent of industry versus the 67 that were industry funded. But again, interpreting this would suggest that there didn't seem to be an overt bias in terms of the results. In fact, the non-industry funded studies seem to have a point estimate that was quite similar to that of the industry funding. In fact, it wasn't on the other side or showing no effect. Now, confidence intervals are hugely wide because the patients are just few. but it gives you some degree of insight that there may not have been a huge bias in that direction. Now, you can still argue there may be, and that's something for you to interpret, but at least based on the data set we have here, we can make some conclusions around that. When we look at other groups' interpretations, you're not alone. So if you had thought that interpreting this data set as others have, which in this particular Cochrane and core review on viscosupplementation suggests that patients, in this particular case, but high molecular weight and cross-link preparations had greater effects according to the Rutjes and colleagues study, you wouldn't be wrong. Now, again, we can argue the validity of all these subgroups, but fundamentally there does seem to be an interpretation that would be consistent with viewpoints of cross-linking and high molecular weights being an area where we might consider focusing future research and future interest. So then you go back to the conclusions of the meta-analysis and you ask yourself, your independent evaluation of the data sets that were presented, are they consistent with the conclusion? And so generally, I tend not to look at the conclusion as my fact. I tend to look at the data. I tend to make my decision about a conclusion. And then I look and see, is it consistent with what the authors have said? If it's inconsistent, then I either go back and try to reflect on it, or I say to myself, I'm going to use my own interpretation of the information that was given to me, because it was given, very, very clearly in the tables. You can decide. But the conclusion that was given in this particular meta-analysis was that the benefit of viscosupplementation on pain and function in patients with symptomatic osteoarthritis is non-existent or minimal. You can argue one way or the other. My interpretation is this is a little bit extreme, and in fact, I would probably be thinking of it slightly more optimistically than was purported. But again, it's an interpretation of the data. So take your own minute or two to take a look at the data set, take a look at the conclusions, look at the tables, and ultimately make your own decisions.